So the most common challenges with treating distal humerus fractures are probably two things. One is the anatomy of the distal humerus. If you're unfamiliar with it, it's complicated, and it's of course a three-dimensional structure, and that can be challenging to treat the fracture fragments. And the second is the exposure relating to treating the distal humerus fracture. So the plates work very nicely because you can get great fixation in the distal part of the humerus with 2.8 screws. They interlock nicely, and they're profiled very nicely on the medial and lateral columns of the distal humerus. The other thing that's quite nice is that there are multiple different options for fixing an olecranon osteotomy if that's the way you'd like to treat distal humerus fractures. And in the first instance, when you're starting off treating distal humerus fractures, it's probably advisable to make your exposure easy by performing an olecranon osteotomy. And so having good, reliable ways of fixing the osteotomy afterwards makes you more confident that you can actually treat the distal humerus fracture with a good exposure and with a good plating system. The other benefit of using a system like this is that there are drill guides that are very helpful in placing the screws in the correct position. And once again, when you're unfamiliar with the distal humerus anatomy, it's very helpful to have a guide like that just increases your confidence. And given the complex nature of the distal humerus, it makes it less likely that you'll have an intra-articular screw at some point that may compromise your fixation or cause a problem down the track for the patient. So there's quite a lot of things that are helpful. The main challenges are exposure and securely fixing the fracture. And if you can get your exposure right, then I think you're halfway there to having a successful outcome. So it's not often that I see a combination of distal humerus and coronoid fracture configurations. It can happen, of course, any kind of combination, particularly with high energy trauma. Fracture patterns are unpredictable because the force that's involved in a high energy trauma is so much more than a normal injury. However, with a typical injury, medium or low energy trauma, typically it's only a single either coronoid, an associated radial head or dislocation type of injury, or a distal humerus, not typically both of them together. So orthopaedic surgeons are creatures of habit, and we'd like to be familiar with a particular type of fixation methodology that we typically use. However, there are always situations that arise when we can't do the things that we'd like to do in the way that we'd like to normally do them. I normally do parallel plating. It's what I'm familiar with, and I find that it gives excellent results. Of course, there are different biomechanical arguments for doing a 90-90 plate construct. However, in my practice, I don't find that I need to do that. But I also understand that there are people who perhaps prefer to do a 90-90 construct, and so I think it's important to have both systems available. It's also true that different fracture configurations do lend themselves more advantageously to either parallel plating or 90-90 plating, and so although I would often do parallel plating, there are certainly circumstances where I've done a 90-90 plating, or in fact I've actually done parallel plating with a direct posterior or posterolateral plate as well. And so having that flexibility just allows for the unexpected or the unusual, where you can address all those different problems with the plates that are on the set. So my standard approach to the distal humerus is to perform paratricipital approaches. I've performed this many times in all sorts of distal humeral fractures, typically the 1, 3, C1, 2s and 3s in fact. Occasionally with a C2 or a C3 I'll have to perform an olecranon osteotomy, particularly if there's an anterior shear component to the fracture, or if there are multiple small comminuted fragments that make it very difficult to piece it together without an olecranon osteotomy with a paratricipital approach. There can be some circumstances where the articular fragments are very hard to put back together, and so I'll perform a chevron olecranon osteotomy. I typically do that with a thin blade to make sure that there's not excessive bone that's removed, and then I complete the chevron osteotomy with a osteotome at the articular surface to make sure that there's not actually any bone loss there. And then following the olecranon osteotomy, I'll use a variety of different ways to fix the olecranon osteotomy back, either with a compression plating technique or perhaps a tension band technique, just depending on the circumstances, and also the soft tissue tension. If I'm thinking that there might be a little bit of soft tissue tension, then there's too much bulk around the plates, I'll put a tension band. Otherwise, I use a compression plating system to be able to compress the olecranon osteotomy at the end of the procedure. So I've known the Medartis distal humeral plating set since around 2014, 2015. My overall impression of it is that it's an excellent system for complex fractures of the distal humerus. I've fixed a lot of these very successfully, and I've found it to be very good for the job. I thought that 2.8 screws were probably not sufficient in the shaft of the distal humerus, and I was concerned that perhaps they would break over time. I was impressed that they were nice, the 2.8 screws were nice around the distal humerus, but I was concerned that in the shaft they may not be enough strength to them. So my initial impression was this is not going to be a strong enough system to use. However, over time, having used it a lot and been persuaded, I persuaded myself when I was looking for a system to use something with small screws. I've never found it to be a problem. And so I now look back at that and think it's interesting that that was my first impression. However, it hasn't borne out to be an issue in the long term at all.